Good afternoon, everyone. I'm Sarah Miller, and I'm the Executive Director of the American Economic Liberties Project. For those of you joining us for the first time, we're a nonprofit, nonpartisan organization focused on addressing today's crisis of concentrated corporate power. It's one, in our view, that contributes to a broad range of deeply entrenched social and economic challenges. One of those challenges is access to affordable medicines. And while there is no shortage of market power abuses in the healthcare industry, pharmacy benefit managers, or PBMs, are a big, but I think generally poorly understood part of the problem, whether contributing to the high cost of life-sustaining drugs like insulin, pushing independent pharmacies that provide critical services to their communities out of business, or ripping off taxpayers by overcharging Medicare and Medicaid. The market power and conduct of the three dominant PBMs deserve to be under the microscope. So let me thank all of you for joining us this afternoon, and I especially want to thank the National Community Pharmacists Association for co-hosting today's program with us. NCPA has been an incredible partner to our organization, and we're super honored to work alongside you on all of this. Over the next hour, we'll be exploring the immense power that PBMs hold over our healthcare system and what is being done to break that power. Over the last 20 years or so, state governments, Congress, healthcare providers, and patient groups have gathered overwhelming evidence that PBMs erode pharmacy and patient care through unfair and predatory tactics. And now we are finally seeing exciting momentum on the federal level to rein these middlemen in. Just a week or two ago, the FTC under Chair Lina, who will join us to close the program today, kicked off a major investigation of PBM business practices. Congress is also pursuing major bipartisan regulation of the PBM industry, which is a historic first. This is thanks to the tireless work of many of the groups represented on the panel today, the American Pharmacists Association, the AIDS Healthcare Foundation, and our co-hosts, NCPA. We're going to kick things off with a message from Senator Sherrod Brown. Senator Brown knows how PBMs have wreaked havoc on patient care in his state and has led the charge to take on these corporate middlemen. He's recorded a message for us that will roll in just a moment, and then Carrie LaViolette, Senior Vice President at the NCPA, will say a few words and introduce Congressman Buddy Carter to continue the program. With that, thanks again, everyone, and let's hear from Senator Brown.
Hi, I'm Sherrod Brown. It's a privilege to serve the people of Ohio in the United States Senate. Thank you to the American Economic Liberties Project and the National Community Pharmacists Association for everything you do. Too many Americans, as we know, struggle to afford the prescription drugs they need. It's one of the biggest costs that so many families face, especially seniors. Prescription drugs are also often among the most overpriced products that people buy. There's no reason most of these drugs need to be as expensive as they are, other than corporate greed. You know that pharmacy benefit managers and the fees they charge are one of the reasons prescription drug costs are so high, and most customers don't even know they exist. These PBMs are essentially corporate middlemen, and because of your work and the work of journalists who have brought attention to PBM abuses, we've already done important work to ban pharmacy gag clauses, to increase transparency, and to ban predatory spread pricing. Earlier this year, we secured action from CMS to finally end DIR fees that put hundreds of independent pharmacies in Ohio just out of business. This is something we've pushed for before, but previous administrations refused. Thanks to the public comments submitted by your organization and others, the FTC is finally investigating PBMs and their predatory practices. We still have more to do, even with CMS's final rule in place, and I thank the Biden administration for that. It will still take too long for these protections to kick in and for Ohioans to feel the savings at the pharmacy counter. Over the coming months, I'll monitor the work CMS is doing. I'll keep working to save Americans money at the pharmacy and keep local pharmacies in business. With so many Americans worried about rising drug prices, we need to stop these corporate middlemen from making the problem even worse. Keep speaking out on these issues. Your work, your voice makes a real difference in this fight. I thank you for that.
Hi, good afternoon. My name is Carrie LaViolette. I'm Senior Vice President of Government Affairs for the National Community Pharmacists Association, and I wanted to thank Sarah and Economic Liberties for partnering with us today. We've been very privileged to be working with them on the PBM issues for quite some time, so I wanted to thank them as well. It's my honor today to introduce you to Congressman Buddy Carter. Congressman Carter is one of two pharmacists serving in Congress. Before his election to Congress in 2014, he owned Carter's Pharmacy for over 30 years, helping patients improve their health outcomes. As a pharmacy owner, he dealt with PBM business practices firsthand and understands how they impact patient access to care in small business pharmacies. As a member of the powerful Energy and Commerce Committee in the House of Representatives, his expertise has helped colleagues better understand the role PBMs play in increasing health costs and limiting patient access to needed medications. He remains a steadfast champion in bringing greater transparency to prescription drug pricing and promoting patient access to pharmacies. In this current Congress, he's the lead sponsor of the Drug Price Transparency and Medicaid Act, and he's also a co-sponsor of the Pharmacy DIR Reform to Reduce Senior Drug Costs Act, the Ensuring Seniors Access to Local Pharmacies Act, and the Equitable Community Access to Pharmacy Services Act. It's my pleasure to turn the program over to the representative of Georgia's 1st Congressional District, Congressman Buddy Carter. But I have learned that he's a little delayed, as members of Congress are with some meetings. So a little bit about the National Community Pharmacists Association, I guess, while we're waiting on him, is we represent independent pharmacy owners, over 20,000 in the United States, many in rural and underserved areas. They're an important part of their communities. Our president, Michelle Belcher, will be speaking later about some of the things she's had to deal with in the PBM space and how they affect her business. It's one of the main parts of their business that they can't control is the PBMs. They can control costs, they can control other things, but it's one part of the system that really needs to be taken at it. We're proud that the FTC is taking a look. We're proud that members of Congress are taking a look. There's really been a big movement to look at this part of the drug supply chain. The drug supply chain is very complicated, and there's a lot of players. It's not as as simple as the manufacturer getting the drug to the pharmacy. There's a lot of middlemen in the system, PBMs being the largest, and have so much control over the pharmaceutical benefit in all programs, in both the commercial and government programs. So we're really happy, to see some movement, like I said, with this FTC study that's coming up that we're going to talk about later, and some actions by Congress. So I think while we're waiting on the congressman, I'll defer to the organizers here on if we want to just keep going with the program and go to the next one and come back to Congressman Carter, if that works for everyone. I think that I'm getting some head nods, so I think that's what we'll do. So I'll hand it over to Morgan.
Great. Well, thank you so much, Carrie. And just like that, we're back. Okay, so we're going to go to the congressman, and then we'll go to the panel. We're back on schedule. Hi,
okay, here we go.
Hey, I apologize. Just too much going on, I tell you. Thank y'all very much for having me, and I do apologize for my tardiness. We're really want to talk about, obviously, PBMs, and I have firsthand experience, unfortunately, with PBMs, having been a retail pharmacist for over 32 years, actually over 40 years. But it's interesting because when I started practicing pharmacy in 1980, PBMs were nothing more than processors. I mean, they didn't have any of the clout that they have now, and that has evolved over time where they have control over formularies. And as all of you know, what the deceptive and unfair practices that they engage in has led now to where it's a threat to retail pharmacy, to independent retail pharmacy, but more importantly, it's a threat to healthcare in America and access to healthcare in America. I say that because 95% of all Americans live within 5 miles of a pharmacy. We are the most accessible healthcare professionals in America. And as that population of retail pharmacies, particularly independent retail pharmacies in rural areas, as that starts to dwindle and starts to get smaller, then access to healthcare is going to be impeded. And look, I'm not opposed to anybody making money, and I'm not opposed to PBMs making money or insurance companies. But at the same time, you can't convince me that they're bringing any value to the healthcare system. Pharmaceutical manufacturers, at least they put money back into research and development. PBMs don't put any money back into research and development. And that's what really irritates me the most, because we spend a lot of time up here in Washington, D.C. talking about prescription drug costs and about what we should do. And we've got very different opinions and ideas on each side of the aisle on what we should do. You know, the Democrats want to go to a system where they use international pricing comparisons. And I think that's just awful, because I think that's going to lead, as we all know, there are governments out there who are subsidizing medications, and that's going to lead to less research and development and less innovation if that happens. So I'm absolutely opposed to that. But I was talking to somebody about it today. I was talking to a colleague about it. You know, the solution is right before us. I mean, the Berkeley Research Group did a study a couple of months ago that showed that only 37% of the price of a medication was going to the pharmaceutical manufacturer. Only 37%, which begs the question, where's the other 63% going? And we know where it's going. It's going to the middleman. It's going to the PBM. That's where it's going. And who is the PBM? I mean, the vertical integration that exists now, where we see the insurance company owning the PBM, which owns the pharmacy, that's where the problem is. That's why when I became a member of Congress 7.5 years ago, the first thing I did was went to the FTC. I said, you know, will you please look at this? I'm telling you, this is the reason why drug prices are so high. Well, I've been persistent for 7.5 years. Finally, the FTC has started a study and approved a study where they're going to look at the unfair and deceptive practices of PBMs and the impact that it's having on independent retail pharmacies. And I applaud them for doing this. I applaud our chairpersons Khan and the commissioners. You know, it's made up of 5 commissioners, 2 Republicans, 2 Democrats, and then chairperson. And and all of them voted in favor. Now, we did have trouble at first because there was some politics involved in it, internal politics within the FTC, but we finally got that worked out. Now we have a study. That's the good news. Now, the unfortunate news is that they're telling us that it's probably going to be 1.5 to 5 years before they come up with their final findings. However, they have also told us that they're not going to wait to make changes just because they haven't got to the final findings. They are going, if they see a problem, they're going to go ahead and address it. And that's good news, because you know as well as I do, they're going to find problems immediately. I mean, you got 3 PBMs that control 80% of the market. And, you know, that's a monopoly right there. That tells you that we don't have the kind of competition that we ought to have and that we need. So this is good news. This is something, as I say, that I've been trying to get them to do for 7.5 years, ever since I've been here and as a member of Congress. And that is to look at the unfair and deceptive practices of PBMs and look at the vertical integration that exists. What's the solution? In my opinion, 2 solutions. First of all, no PBM should be able to take rebates, cut out rebates. You know, we've talked about, make rebates at the point of sale. Well, that's fine, but you just cut out rebates completely. That would do away with it. That would solve one of the biggest problems. The second thing is to prohibit PBMs from owning pharmacies. You know as well as I do, they're steering. We see it every day. Even when I was still practicing, I saw it. Steering their patients, particularly in a specialty pharmacy. Oh, they are steering their patients all day long. I want to share a story with you. I had a daughter who said that her mother had cancer. And you've probably heard these stories before. You probably have stories of your own, but her mother had cancer. She had to wait. I believe it was 4 weeks, almost a month, before she could get the cancer drug that she needed. Well, by that time, they had to put her in hospice. And the next week, her mother died. Now, I don't know whether, and she doesn't know whether the cancer drug would have worked or not. But what the PBM did was to rob them of hope. That's exactly what they did. They robbed that family of hope, requiring them to wait a month before they could get that drug. That is just ridiculous. And that's the kind of thing that I'm going to make sure the FTC hears these stories. And I would encourage you, if you've got stories like this, and I'm sure you do, you share those stories as well. Share them with the FTC, share them with my office. I'll make sure they get to the FTC. That's the kind of thing that we need to hear. You know, all kind of examples. You know how it is. There was another example where in a pharmacy that was providing medications for a jail, that the PBM billed the jail $200 for the medication and gave the pharmacy $5. You know, here's a company, a pharmacy having to keep this product on their shelf, and then they're going to get $5 for it. And a lot of times you don't even get that much for it, but it's just ridiculous. And that's why, again, I'm excited about this study by the FTC. It's a 6B study is what they call it. And they are looking at this, and I'm looking forward with great anticipation what they come up with. We're going to be following it. We got a good relationship in our office with Chairwoman Khan and with the commissioners as well. I've talked to them all personally. So we're going to be, and with the staff, which is extremely important, as you know. But we're going to be following this, and we're going to be working with them to make sure they're asking the right questions. That was the problem at first, is that the format and the questions that they wanted to ask, they couldn't get together on that, but they finally got together on it. So we're excited about it and looking forward to it. And I just wanted to bring you up to date on that, because it is a big win for pharmacy, and it's a win that we've been trying to get done for a long time. And the reason it's a big win for pharmacy is because it's going to result in lower drug prices and therefore in better patient care. And that's our ultimate goal, better patient care. So thank you all again for having me. I appreciate the opportunity, and I'll yield back now, and glad to answer any questions or make any other comments if you need me to.
Well, thank you so much, Congressman Carter. We very much appreciate your insights, especially being both a congressman and a practitioner, and we're grateful for your time. So thank you.
Thank y'all.
And encourage people to take you up on your offer to let you know about their stories and pass those on to the FTC.
If I could just interject this, let me tell you, your advocacy is so vitally important up here in Washington, D.C. Getting in touch with your congressperson and letting them know, you know, we're a citizen legislature. I mean, we have everything from preachers to almond grove farmers to blueberry farmers to pharmacists to thoracic surgeons. I mean, we got everything up here. That's why we rely on each other. And every day, and I'm not exaggerating, I have someone come up to me, a member of Congress, saying, I didn't know you were a pharmacist. I had a pharmacist in my district who told me yesterday, you are a pharmacist and you've got a bill that I need to get on. Or you've got a letter that you're leading and I need to get my signature on that. So please make sure your staff contacts my staff. That happens all the time up here. And we rely on each other. I do the same thing. When I've got a question about legislation dealing with new car sales, I go to the new car sales owner, ask him about it. When I got a question dealing with, you know, whatever it may be, I go to that person whose expertise is in that field. That's why it's so important we have grassroots advocacy. So thank y'all for that. And stories work much better than just you telling them. I can tell them all day long until I'm blue in the face. But if you can get a patient, especially like we had with this daughter whose mother had cancer and couldn't get the cancer drug, that's strong. That gets their attention. So again, thank y'all.
Thank you. And I think that's a pretty good segue into our panel, which is going to feature both practitioners and patient perspectives. And my name is Morgan Harper. I'm Director of Policy and Advocacy at the American Economic Liberties Project and have the honor of moderating the panel. I'll give some brief introductions of our panelists, and then we'll get right to the discussion. So first, we have Michelle Belcher, who is the president of the National Community Pharmacists Association, our co-host for the event, and the owner of Grants Pass Pharmacy in Grants Pass, Oregon. Grants Pass has been in the community since 1933 and is the last remaining independent pharmacy in the area. Michelle is also active in our state pharmacy coalition and has served on task force groups for the State Board of Pharmacy. Thanks, Michelle. We have Randy Mcdonough, who is Professor of Pharmacy Management and Innovation at Loma Linda University School of Pharmacy and co-owner of Towncrest, Solon, Towncrest, and Towncrest Compounding Pharmacies. It's a mouthful, but Randy's up to a lot. And he's also co-founder and co-owner of Innovative Pharmacy Solutions. So in these roles, he's responsible for development, implementation, and quality assurance for all aspects of the clinic and services. We have Ray Patnod next, who is our patient, and he is offering the patient perspective. He is a psoriatic arthritis patient and a father of 6 based in Michigan. As an Ohio resident, I'm not going to hold it against you. You still get to be on the panel. For more than a decade, he has worked with national and international patient advocacy organizations to educate patients and to advance patient-centered healthcare policies. Thanks for being with us, Ray. And then last but not least, we have Dr. Michael Wolfiler. Dr. Wolfie, I've received permission to use his name that he goes by for this. He served as the Chief Medical Officer for the AIDS Healthcare Foundation since 2013, and he has been treating HIV/AIDS patients since 1987. In addition to operating a private practice specializing in this treatment, he's also developed some of the nation's first hospice guidelines specifically for AIDS patients. Before joining AHF, he was the medical director for special immunology services at Mercy Hospital in Miami. Thank you to all of our panelists for being with us. We're really, really grateful. Like the Congressman said, we lead with storytelling and also the experiences of business owners. And so we're happy to have you all further educate the public about what's going on with PBM Power. So to kick things off, though, we want to make sure that people understand the role of independent pharmacies, community pharmacies. And so to start, we want to turn to Randy and Michelle, maybe starting with Randy, then go to Michelle about just what is the role of the independent pharmacy in your area? How has it come that a lot of patients are relying on your services? And what's the experience like of being a brick and mortar community independent pharmacy?
Morgan, thank you. And I also appreciate being part of the panel today. And this is something that's near and dear to me as I've been fighting this battle with PBMs for a long period of time. As far as my business partners and I, we currently own 3 community independent pharmacies, with 2 of them located in rural areas. In each of our practices, our patients rely on us to be one of their trusted healthcare professionals, providing oversight of their medications, helping them optimize their medications, and also working collaboratively with the other healthcare providers in the area. You know, our value to our patients is our accessibility, our expertise to help them optimize their medications, and by providing consultations, advice, and clinical services. Our patient care services can range from a robust vaccination program to medication management services with specialized clinical services in between, such as point of care testing, drug information, and a vast array of durable medical equipment options, including CPAPs, diabetic shoes, compression stockings, wound care, and ostomy supplies. Our patients expect us to help them with their medication issues and concerns. We go into every patient encounter with 3 questions in mind. Are their medications safe? Are their medications effective? And have they reached a therapeutic outcome? If we answer no, or we don't know, then we need to either collect more information or intervene to resolve the medication issue. We go into that patient encounter expecting to find a medication-related problem, and most times we are correct. You know, I frequently cite that in the 1990s, we used to say for every $1 we spend on drug therapy, we spend another $1 to correct the problems associated with that drug therapy. In 2016, that estimate increased to $1.51 being spent on correcting the problems associated with drug therapy. And that's where community pharmacists become an important member of the healthcare team, ensuring that patients' medications are optimized by identifying and resolving medication-related problems, provide ongoing medication management and monitoring services, and also collaborating with other healthcare providers. It's not just about dispensing medications. It's about ensuring that the right medication for the right patient with the right dose and appropriate follow-up monitoring is occurring. As I mentioned, we have 2 pharmacies are located in rural areas. In those instances, we are the essential healthcare provider. Patients rely on us not only for access to pharmaceuticals, but also, as I mentioned above, that we have critical medication management service, durable medical equipment, over-the-counter products, and other services that they're looking for. For us, it's not just about being a local business, but rather how we can be a solution for our communities, whether it be providing vaccinations, point of care testing, health promotions, or medication management. We personalize and optimize the care for each of our patients. And this actually became something that was really highlighted during the COVID-19 pandemic.
Yeah, I was going to say, I think for a lot of people, because in some areas there might not be an independent pharmacy anymore, but especially a lot of the coverage of the pandemic and just how important community pharmacies were in treating patients and being that first line medical provider, I think highlighted that for a lot of folks. Michelle, did you want to add?
Thank you, Morgan. COVID did give a highly visible example of how nimble and reactive independent community pharmacies are as businesses. I was contacted back in January of 2021 that a vulnerable population in our community, an adult developmentally disabled foster care patient population, were not going to be vaccinated by the federally contracted big box pharmacies. Within 2 days, I was able to set up a clinic where we vaccinated all the patients and their caregivers. And I know that there are thousands of stories and examples like this from my independent pharmacy colleagues across the country. Brick and mortar independent pharmacies are embedded in our communities. We not only take care of our patients, but we help our community partners solve the healthcare problems of the individuals living there. Communities lose every time an independent community pharmacy is forced to close their doors because of the unfair practices of PBMs.
Great, thank you, Michelle. And for both of you, and maybe starting with Michelle on this one, then going to Randy. I mean, what has been the impact of having PBMs gain this type of concentrated power? The congressman also alluded to in just how much the role of a pharmacist has changed, or their power has changed over time since he started practicing. But if you both could speak to that a little bit.
Well, I guess I would list several things that come to mind in terms of the ways that PBMs just make it an unlevel playing field for us. PBMs control the access to patients, to my patients, by acting as network gatekeepers. Every year, we have hundreds of conversations with our patients who are suddenly steered to PBM affiliated pharmacies because of changes that they seemingly randomly make in their networks. They offer take it or leave it contracts that reimburse my pharmacy below the actual cost of many medications. They use the data of my patients as another way of steering patients to their own affiliated pharmacies, as the congressman used as an example, especially to our, to many other pharmacies. They access or assess point of sale fees based on arbitrary performance measures. And lastly, we undergo onerous audits that are done with the threat of network termination. And it's really unbearable, and we're seeing many of our colleagues being forced to close their doors.
Morgan, to follow up with those comments, I will tell you that it's very similar to us. Everything that was just mentioned is exactly occurring within our pharmacy. And the thing I'd really emphasize is the unfair reimbursement has made it challenged for us as a practice. But in Iowa, over a 2-year period, we lost over 40 pharmacies. And again, that's occurring in areas that usually are rural, since Iowa's a very rural state, which is leading to problems of access to care and pharmacy deserts and other things. Whether we're dealing with retroactive DIR fees or just the lowest effective price at the point of sale, the reimbursement is just insufficient to dispense medications, let alone providing medication management services that I talked about that are critical to our patient care. The PBMs have created a preferred provider concept that has nothing to do with the quality of patient care provided, but rather who's willing to take the worst contract. And over the past 10 years, we've seen contracts continually worsen. This has translated into a scenario where we were a preferred provider in most of the contracts 10 years ago to now only one, probably not going to be any in the future, which then causes our patients to be steered to those pharmacies that accept those contracts, with the PBM-owned pharmacies benefiting from their own contracts. Just today, I had a patient bring in a letter that's very confusing from a PBM where they feel like they're being pressured to move to a PBM-owned pharmacy. So it's an unfair, non-transparent system that heavily stacks in the favor of the PBM.
And why can't, because this is a pretty broad audience, but just to make the point very clear, I mean, why can't you all just go somewhere else? Or why do you have to continue to engage with the big three PBMs?
So as an example, my percentage of the big three PBMs is over 67% of the insurance-based plans that my patients bring in. And so to give up 67% of my business would, likely force me out of business. And so it's not an option for us.
I would totally agree. We have similar percentages. So the simple answer is no, we have to continue working with the PBMs. If we did not contract with them, then those patients that we take care of would be given a very difficult choice. Leave us, the healthcare provider who they developed a therapeutic relationship, and perhaps the only pharmacy within driving distance of their home will go to a mail order pharmacy. The other thing I want to emphasize is I care deeply for our patients, and our practice philosophy with my business partners is that we treat each patient as if they were a family member. When you practice that way, you do all that you can to be their healthcare provider, including being forced to do business with a PBM who's detrimental to your future viability. It's really our own catch-22. And all I'm saying is that drug prices continue to rise, patients continue to pay more out of pocket, and pharmacies getting paid less and less. Truly an unsustainable model. The PBMs create a system that has manipulated to their favor with little power given to patients or pharmacists to do anything about it. So the PBM approach of take it or leave it has made it extremely challenging to continue to be a viable business, causing the closure of pharmacies, as I've mentioned, and the emergence of more and more pharmacy deserts.
Well, Michelle, did you want to add something?
Yeah, I would like to say that having conversations with patients when they're steered to a mail order pharmacy after you've been taking care of them for literally, sometimes their family for generations. My father owned pharmacy prior to me, and it's so emotional for them to have to come in and say, I can't do business in your pharmacy anymore because I am being forced to go to this mail order pharmacy. And yet they say, and I have nobody though that will be able to answer the questions that I have that you've always answered for me. And so, it's something that we will often say, please, continue to know that you can come to us to answer your questions. Because when they receive something in the mail, who's there to talk to them about their medicine, explain it, go over, the information that is necessary, that any patient should be able to have that conversation with their pharmacist.
So you're saying, so even after one of your patients might switch to a mail order pharmacy, you're still kind of providing advisory services to them in some cases to help them understand what's going on?
Absolutely. I would dare to guess that the majority of my colleagues offer the same service, because the reality is we have face-to-face interactions and relationships with these people. And we want them to, have the knowledge to be able to have the ultimate benefit of that medication. So absolutely.
And Morgan, if I can add to that, the term that I use, therapeutic relationship, I don't use that term, loosely. And what I mean by a therapeutic relationship is, we have a friendly relationship with our patients and they trust us, but it's really as a healthcare provider why they come to us. And it's that therapeutic relationship where we make a promise to them that we'll take all of our skills, all of our knowledge to make sure that they're getting their medications optimized. And in return, they have to be honest and open with us, give us the information that we need. It takes a long time to build that kind of a trust, that kind of therapeutic relationship. That when you talk about the brick and mortar pharmacies, these independent pharmacies that might be the only ones in their community, it's that trusted healthcare provider. That's the difference. And that's when you really can impact someone's healthcare, is when you have that give and take of trust between the two individuals.
Well, thank you to both. And I think that the trust, and it's very clear from how you all talk about how you're interacting with your patients. And I think, a good segue to talk to Dr. Wolfe about helping to treat patients with a very serious illness and what your experience has been like with PBMs and how that's impacted your ability to care for your patients and what you've observed over time as well.
Sure. No. At AHF, obviously our focus is on HIV positive patients. We're a safety net provider. We don't turn away anybody. We treat every HIV patient regardless of their ability to pay. And, HIV is a good example of a type of illness that requires a certain degree of expertise, and because it's complicated, and the medications used to treat HIV, the antiretrovirals, are complicated. And so, for instance, we can't cure HIV at this point, but we can keep the virus chronically suppressed and keep people healthy by doing that. But the medications, the antiretrovirals that are used to accomplish that, have potential for really quite serious side effects, such as renal impairment, loss of bone density, liver toxicity. They also have a lot of significant drug interactions when they're used with other medications, and they require a high level of adherence. I mean, we're talking about 90 patients have to take about 95% of their doses, or else the virus may become resistant to the medications, and then they've lost the patient has lost those treatments probably forever. So adherence is a much bigger issue in HIV than some other medical conditions. And then, just as the meds are complex, so are our patients. I mean, HIV patients have higher rates of comorbid conditions like diabetes and heart disease, and some cancers, osteoporosis, and a lot of them have co-infection with hepatitis B or C. And then on top of that, the median age of an HIV patient now is over 50 in the US. And so they're developing age-related problems as well. And so all of this paints a picture of a patient population that is unique and vulnerable, and that requires management by doctors and pharmacists who are specially trained and experts in the field of HIV medicine. And if you go to for my patients who are basically forced into mail order specialty pharmacies, which is happening more and more with this vertical integration, this increased vertical integration between PBMs, insurers, and pharmacy chains. I don't know if PBMs and these mail order pharmacies don't understand the complexity of treating HIV patients, or they just willfully choose to ignore it. I kind of think it's the latter. What happens then is that they push our patients into these mail order pharmacies, specialty pharmacies that are affiliated, with the PBMs and the insurers, and they're not the pharmacies that the patient chooses. It's pharmacies that the insurer and PBM wants them to use, not that the patient wants to use. And I can tell you that every single patient who goes into who's unable to use our AHF pharmacy and is forced into one of these mail orders, every single one of them has had problems. And they, I myself have frequently had to call, PBMs or the affiliated mail order pharmacies. And I can tell you that they have no understanding of HIV medicine or HIV patients, to the point that I'm often having to spell or pronounce the name of the HIV medication because they've never heard of it. They are unaware of potential side effects and drug interactions. They don't understand that HIV patients cannot miss doses of their medications, and that delayed or wrong medications shipments are literally life-threatening. And if you contrast that to our AHF pharmacies, which are co-located with our clinics, all of our pharmacists are certified experts in HIV medication, and they are an absolutely critical part of the patient's clinical care team. As was just mentioned about community pharmacies, our patients develop really strong relationships with the AHF pharmacy and the entire pharmacy team. And that relationship becomes really key to patients remaining in care, remaining adherent to their antiretrovirals. Our pharmacies do things like, if a patient hasn't picked up their antiretrovirals in 35 days, if there's been a period of 35 days where they haven't gotten a refill, they call that patient directly, to make sure that they're still taking their medications. We provide free adherence packaging like calendar packs and go packs. We provide free home delivery of medications or overnight FedEx of medications, all at no charge. And I've had fights with PBMs and mail order pharmacies where I'm like, they screwed up, and they're telling me, well, okay, so we'll get the medication to the patient in 1 or 2 weeks. And I'm like, they can't be off their medication for that long. And they don't care. They don't get it. And the last thing I want to mention is regarding the DIR fees, because, just looking at AHF, the PBMs have clawed back millions of dollars from AHF and other safety net providers, nonprofit safety net providers. And it just kills me that they say that these DIR fees are based on quality metrics that are intended to improve patient care, when in reality, the metrics that they set are arbitrary, they're irrelevant, and they're nothing more than a blatant method of increasing PBM revenue. An example that affects us at AHF is that, one of the metrics they often use is generic dispensing rate. And so we get penalized for not meeting this metric, even though it is literally impossible for us to meet it, because virtually every currently recommended antiretroviral medication is not available as a generic. I mean, we can't meet the metric, and yet they use that as an excuse to claw back all this money. And this is money, the millions of dollars that they're clawing back from a nonprofit like AHF is money that would have gone into providing direct patient services, but now is instead just going into the coffers of these multi-billion-dollar for-profit PBMs. And so, to me, PBMs and the associated health plans and mail order pharmacies that are all tied together now are quite literally profiting off the backs of at-risk patients with life-threatening illnesses. And, I don't know what the original thinking was for creating PBMs. Maybe there were valid reasons at the beginning, but what I do know is that as they exist now, all they do is limit patient choice, undermine patient care, divert money away from patient care, and that they, are in particular impacting patients with, serious and often life-threatening medical conditions, because those are the ones who especially use the specialty pharmacies. So, yeah, I mean, I just, I see absolutely nothing good that comes from PBMs.
Thank you, Dr. Wolfe. And Ray, I mean, want to turn to you. We've heard a lot of talk about dealing with patients and navigating illness. And if you could just speak to what your experience has been in trying to deal with this and to be able to get the treatment that you need.
Absolutely. Thank you, Morgan. Well, you know, the way it is to deal with these PBMs, first let me say I have psoriatic arthritis, and as the name suggests, this condition is composed of arthritis, inflammation of the joints, and joint pain, and loss of motion and pain, and also psoriasis, which is a skin condition that can just get out of control and come down your arm and inflame. So those are the two conditions that I need to treat. So when I started my journey with this condition about 5 years ago, I had small children, and I realized I couldn't hold their hands in the parking lot, and they could run out and dart out in front of cars. Or I would grab a thing of milk and it'd slip out of my hand in the grocery store, and I'd waste all the milk and make a big mess. And I said, well, this is unsustainable. So I went to my general practitioner, who said, you need to get systemic treatment for both of these conditions. I went to a dermatologist. This person could have started me on a biologic, but the insurance, the PBM said, no, you have to fail. They have a whole list of all these medications that you need to fail before you can go and get on a real medicine, the big guns, which would be a first line treatment, you know, in an ideal situation. But they're trying to go and control costs of limited healthcare resources. I get it. So I tried methotrexate, and we tried it in a few different variations, you know, subcutaneous as a little pill. We tried a bunch of different things, and I started getting stomach problems, hair falling out, so that didn't work. After, you know, months and months and months of this, they tried an old drug, a cheap old drug, 1950s drug called Sulfasalazine. All right. Again, a lot of this is a delay tactic because they don't want to go and get you the real good drugs first. But anyway, so we fast forward. Eventually, I get on this small molecule drug called Otezla, which is fantastic. And I'm not doing a commercial for it. I'm saying that it instantly cleared up all of my psoriasis, just instantly within 2 weeks. It was a miracle drug. But the joints were out of control. So much pain, inflammation, joint damage, ordinary activities that anybody else should be able to do, I can't do. So eventually, I had to get on a biologic. The biologic had the other problem, and it's a great drug. It's Cosentyx. It fixes the joints perfectly, but not the skin. So after going with my rheumatologist over and over again, jumping through all these hoops with the PBM, I could not. I tried to get on Otezla to fix the skin because the joints were okay. And the PBM says, no, you need to fail a double dose of the biologic. Now, these biologics are really, really expensive drugs. They're complex molecules. They have a much, much higher list price than these smaller molecules, these chemical drugs, like the pill I was taking that helped my skin. So after 9 months of being on a double dose, an unnecessary extra biologic dose, that was, you know, this is not optimized. This is not, you know, keep getting people on the right medicine. This is not saving money for the health system. This is all a black box. We have no idea what's going on. My suspicion is that they're getting a higher rebate for that biologic product because those are typically calculated as a percentage of the list price. So it's optimized not for the patient here. I can't get on Otezla and the biologic. I can't get on the things that my doctor and I have chosen after looking at my treatment history and my unique condition. Treatment plans aren't one size fits all. And we've come up with this, and you know we're going through appeals and independent review and charity foundations, just trying to get the right medicine that I need. And we're not saving money for the healthcare system by putting people on a double dose of a biologic they don't need that's unnecessary. That's not optimized unless your objective is to just increase profits for the PBM. And their stock is doing very well over the past 5 years while my joints are getting damaged.
Well, thank you, Ray, for sharing your story. And yeah, I mean, it's pretty telling in your story that it's not you and your provider, your doctor, who are leading your treatment. You have to defer to the whims of the PBMs, which seems a little backwards. So for the whole panel, because we only have a couple minutes left before we transition to closing remarks, wanted to focus on solutions and what you see. We've heard a few terms thrown around: vertical integration, DIR, rebates. If y'all could talk about what specifically needs to be done to improve your ability to both do your job, run your businesses, and seek the care that you need. And maybe we'll take it back to Randy and Michelle, and then I'll circle back to the panel.
I think from my perspective, some of the things that we addressed, you talk about vertical integration, doesn't seem to be working. It just gives more power to a small group of companies that can make the decisions regarding the care. I think, for me, it's recognizing what pharmacists are doing and not saying that we're just a product and that here's how we're going to price this product, but looking at the value that pharmacists bring to caring for these patients. Listening to the last two panel individuals, talking about the care from a physician perspective, talking about the care to the patient. We've been involved in all that, and it's very frustrating to a physician when we're going through all this prior authorization and nothing seems to be happening. We just keep waiting and waiting for this needed treatment. Same thing is true for a patient. And the last thing I'll say is we have a patient who has psoriatic arthritis who has to go to a different place or go to a different pharmacy to get their psoriatic medication, right? Their psoriatic arthritis medication. They stay with us. Their father was a pharmacist. They understand the value of having that pharmacist care for all their medication needs. So she makes sure we understand exactly how she's doing, what she's doing with the medications. But that to me is just fragmenting care more. So you talk about the drug interactions. You're right. If I don't have that patient who understands that they got to give me that information, now you've got fragmented care that we're not getting the full picture of that patient. So we need to level the playing field to allow our patients the freedom of choice to come to our pharmacy because of the therapeutic relationship and make sure we're paid a fair fee to manage that patient.
Great. Thank you, Randy. Michelle?
And I would absolutely agree on everything Randy said, as well as, there are examples when we talk about the huge, price increases in insulin, for instance. We have patients that, one in particular that we noticed had not, received their monthly refill that they should have gotten. And it had been, was about 15 days past the time that they should have been out. And so we made a call to that patient to say, has there been a change in your therapy? And the patient, through some continued questioning, finally admitted, I can't afford the copay, that I have actually been taking the dose every other day. And so we have patients that are making decisions on their care because they can't afford a medication. And we've got to figure out what we need to do in order that patients are not compromising their overall health because of the cost of their medication. So, I think that the vertical integration just continues when we're having to compete with a vertically integrated entity that is steering their, the patients to their downstream PBM pharmacies. We need to make sure, and yet when a patient comes to us, are, reimbursing us at an unfair, discriminatory way, we need to evaluate that.
Morgan, can I add one thing, because I know we're running out of time, but the one thing that was mentioned with Congressman Carter was spread pricing. He talked about the gel. That actually happened in Iowa. I was part of a congressional oversight committee that I testified against some of the things that were going on, and maybe it was another place too, but the point is there's spread pricing. So as we look at the cost of medications and what the patient is paying versus what the pharmacist is getting reimbursed and what's happening in the middle, it's that spread pricing that's causing the cost of all these medications to go up so much, and without the benefit of the patient paying less money. So we've got to just break that system apart.
Great. And then, low on time, but both Ray, Mike, Dr. Wolfe, any final thoughts? Ray?
So, I just briefly, patients, in my mind, patients should have choice of which pharmacy they use. I don't see any good reasons to deny them that choice. And then the other thing is, get rid of these DIR fees. They're absurd. I mean, it's such a blatant ripoff. So anyway.
Great. And Ray, final word.
Transparency. In a word, transparency. If we can see what's going on within the formulary design and construction, we can see whether people are really getting the medicines that they need, or they're just getting the medicines that are the most profitable for the PBM, whether they are helping the patient or not.
Great. Well, thank you to our entire panel. Really appreciate your candor, openness about your businesses, your experiences as patients and doctors. And we're very grateful to be able to have you as part of our conversation here, Economic Liberties and NCPA. So with that, we will turn it to our closing keynote speaker, Chair Khan. I'll give brief introduction and let her get to it. So Chair Khan was sworn in as the chair of the Federal Trade Commission on June 15th, 2021. So she recently celebrated her first anniversary as chair. And prior to that, she was an associate professor of law at Columbia Law School and has also been a counsel at the U.S. House Judiciary Committee and a legal advisor at the FTC. So Chair Khan, turn it to you.
Thanks so much, Morgan, for the introduction, and thanks so much to the American Economic Liberties Project and the National Community Pharmacists Association for organizing this important event. I've learned so much from the panel discussion and from our speakers earlier. I'm so grateful to Senator Brown and Representative Carter for their unrelenting efforts to shed light on the problems in these markets. And more broadly to the many, many patient advocates and medical professionals who've shared their thoughts and expertise to help policymakers really grasp the business practices that we're seeing in this market and their effects. As we've heard, pharmacy benefit managers and other intermediaries now play a critical role that has enormous consequences on people's day-to-day lives. Their decisions help determine which medicines are prescribed, which pharmacies patients can use, and the price that patients ultimately pay at the pharmacy counter. They can also determine whether independent pharmacies can compete and thrive, which, given the key role that community pharmacies play in providing efficient and affordable access, is critical. We've also seen that not only does the PBM industry play a central role in determining what medicines and pharmacies we can access and at what price, but the market in which they operate is also extremely opaque and complex. This combination of, on the one hand, wielding extraordinary influence and even having life and death consequences, and on the other, of being extraordinarily opaque and complex, is a combination that's always worth scrutinizing. As the FTC has sought to update its understanding of this important market, we've been aided by many, many people in the patient advocacy community and the pharmacy and medical community more broadly. In February, we put out a call for comments on PBM's practices and their impact, and we received more than 1,200 individual comments from more than 24,000 parties, which is one of the largest number of comments that the FTC has received on any issue. We've also had many patient advocates and pharmacists and healthcare professionals come speak at our open meetings. So we've just had remarkable participation and engagement for which I'm extremely grateful. We at the FTC, I think, benefit extraordinarily when we're hearing directly from people on the ground in these markets that are actually producing and consuming goods and services. And so I'm just so grateful for everybody who's been so engaged with us. As you know, partially in response to the striking number of comments and engagement, the Federal Trade Commission recently voted to conduct a market inquiry of pharmacy benefit managers and the impact of their business practices. This means that we're sending out orders requesting information from the big PBMs that will shed light on a variety of issues. So we're looking at some of the issues that we most often heard complaints about. So this includes unfair fees and clawbacks, reimbursement terms that may pay pharmacies below their cost of acquisition, methods that are steering patients to PBM-owned specialty and mail-order pharmacies, pharmacy audits, and the impact of PBM rebates on competition and ultimately patients' costs. The FTC also just last week voted in favor of an enforcement policy statement, which really lays out how our existing legal tools and authorities apply to PBM's rebating practices. So specifically, we noted our intention to examine the effects of the rebates that drug manufacturers pay to PBMs. We've heard many concerns that these rebates might function as kickbacks in some instances, and that drug manufacturers may effectively be paying PBMs to exclude cheaper drugs like generics and biosimilars from their formularies, which in practice means that fewer patients have access to more affordable medicines, and they're instead left paying more money or not being able to afford medicine at all. At our commission meetings, we've also heard just devastating accounts of how people have lost family members who've had to forego or ration essential medicines because of these high costs. We've heard a striking number of these stories in the context of insulin, where the wholesale price nearly tripled between 2009 and 2017. And so we really undertake this work with a fierce sense of urgency. I'm really thrilled that the FTC was able to make headway on getting these two important actions started. These actions are truly just the first steps, and we have a long road ahead. As we noted in our statement last week, if we find any illegal practices in these markets, be it unfair methods of competition, commercial bribery practices, or unfair or deceptive practices, we'll be sure to bring our full authorities to bear and enforce the law. I wanted to close just with two broader observations. First, it's so critical to remember that the current structure of the market and the current structure of the industry and the types of business practices that occur, none of this is inevitable or some inexorable force of nature. All of these features of our current system are the result of policy choices and legal decisions that were made by people, including officials at the FTC and the Antitrust Division, but also public officials who are elected and directly accountable to you. So it was policy choices that permitted PBMs to merge with one another and created a more concentrated market. It was policy choices that permitted PBMs to vertically merge with health insurance companies on one side and specialty and retail pharmacies on the other side, which many have noted can create a sharp conflict of interest. And it was policy choices that allowed the largest insurance companies and hospitals and private equity firms to buy up thousands of physician practices, which many have claimed has really degraded patient care. So there's nothing inevitable about the current structure of the market or the current business practices that occur and are permitted. These are all the results of policy and legal choices that were made by public officials and that can also be remade by public officials through the democratic process. The second thing is that while the FTC has a critical role to play here, we are just one of the many public entities whose work can make a difference here. So the responsibility for crafting how our healthcare markets are working is divided among dozens of state and federal authorities who are also ultimately accountable to elected members of local, state, and federal legislative bodies. And so I think it's vitally important that this remarkable advocacy community remains engaged with this broader group of decision makers to educate them about which policies will make our markets work so that we can all have access to affordable medicines and high quality healthcare, including at pharmacies. So I say this just to encourage everybody to view these key questions of commerce as key democratic choices for all of us. We all know that these decisions and choices will be made regardless. It's just a question of who is making them and with what goals and what accountability. So I hope that everybody here, the patient advocates, the pharmacists, the healthcare providers, and just the concerned citizens will remain fully engaged to ensure that your voices are heard at all levels of government. We've certainly benefited immensely from your active participation at the FTC, for which I'm incredibly grateful, and I'm hopeful that together we'll be able to make real progress. So thank you so much again to the organizers for putting together this important event, and it was really great to hear and learn from you all.
Thank you, Chair Khan. Really, really powerful remarks, and just reminding us all of the role that we have to play in making sure that our democracy and our institutions fulfill their mission of looking out for us. So really appreciate your time today. And thank you to all of our panelists again for participating, to Senator Brown for his opening remarks, to Congressman Carter, and to really all of the advocacy work that has been done by both NCPA, our co-host, and a lot of other organizations and patients and practitioners to bring attention to this issue that has been going on for years. So we will continue to amplify and do what we can to move it forward. And we're grateful for all of you for joining us today. And I will just finally plug, we have a quick take that we released today as an organization, American Economic Liberties Project, that also provides more of an overview of some of the issues that we discussed. So check that out as well. Thank you, everyone. Have a great day.